Welcome back, everyone, to the ASCO Journal of Oncology Practice podcast. My name is Dr. Nate Pinnell, medical oncologist at the Cleveland Clinic and consultant editor for the JOP. Now, in an effort to rein in the rising costs of healthcare for cancer patients, the Center for Medicare and Medicaid Services initiated an alternative payment program called the Oncology Care Model, or OCM, which we covered in a couple of JOP podcasts in April and then again in August of 2015 when the OCM was just being introduced. Now, while ambitious in scope and with noble intentions, the introduction of the OCM has not been without challenges, and the CMS actually wanted to address these challenges in a publication in the JOP. So I think it's worthwhile to have a discussion about this. Now, joining me today on this topic is Dr. Blaise Polite, Associate Professor of Medicine at the University of Chicago, where he's also the Deputy Section Chief for Clinical Operations and Executive Medical Director for Cancer Accountable Care. Dr. Polite has also been a past chair of both the ASCO Cost of Cancer Care Task Force and the Government Relations Committee. We'll be discussing the publication that came out in May of 2017 called Design Challenges of an Episode-Based Payment Model in Oncology, the CMS Oncology Care Model, by Dr. Ronald Klein and his colleagues at the CMS. Dr. Polite, thanks so much for joining me.
Oh, great to be on. Thanks for having me.
So if you wouldn't mind, because it is a little bit complicated, could you give me a little bit of background? What was the purpose behind the OCM and how generally was it designed?
The OCM follows a model that the Center for Medicare and Medicaid Innovation had been taking in areas such as orthopedics with hips and knees. And the idea was to create a bundled payment system, if you will. So the idea is, can we better incentivize healthcare systems to take a more sort of holistic view of the cancer patient and really try to look at the things that happen outside of our offices, right? So what happens, when people show up to emergency rooms, go to skilled nursing facilities, et cetera. And so they decided that oncology being, one of the major drivers for costs in the Medicare market, that was a place that really needed for them to take a look at a value-based model. And so they came up with the oncology care model, which, as you can, I think all of our listeners here can understand, when you look at something like cancer, which we all know is certainly not one disease, but probably thousands of diseases. So to try to come up with a model that creates, essentially bundles of care in cancer is no small feat. But, I think to the credit of the Center for Medicare and Medicaid Services, CMS, they put a very noble effort forward. And in doing so, and I think that the point of the article that is in this issue is for them to really lay out a lot of the decisions they had to make. And a lot of the decisions I think that they've gotten some criticism over, but I think for them to try to lay their case out of these were the alternatives we considered and this is why we went the way we did.
No, I agree. It actually was a big help to me to read this article. And where exactly is the OCM and its implementation?
We are now nearing the end of year one. So July 1, 2016, the model rolled out. It rolled out with over 190 oncology practices and 16 private payers around the country. I think Medicare estimates that somewhere in the vicinity of 20% of all Medicare cancer patients are going to be involved in the oncology care model.
Okay, so if you don't mind, I was just going to kind of go through the paper a section at a time and through each of these challenges. So the first one, of course, is how they came up with designing their what they call episodes of care and how they came up with the 6-month period. How did they come up with that design, and how well do you think that really meaningfully represents how we treat cancer patients?
Well, so the first thing, they had to decide where do you start the clock with a cancer patient. And, we can think about, you could start it at surgery, you could start it at other places. They found that starting at chemotherapy appeared to have the least amount of variability, right? That it looked like it was a pretty predictable set of things that would happen around the time someone would get chemotherapy. So they wanted to create episodes that encompass most of the care, or at least a predictable amount of care for patients. Why the 6 months? There's no strong reason for 6 months other than what they essentially saw is that in the first 2 to 3 months, you tend to see most of your spending on patients, and then it begins to sort of filter out. And by the time you get to 6 months, you're not seeing sort of a lot of variability in cost on most patients. Again, they were trying to see, can I capture the majority of variability in spending that is happening in a cancer patient? And so this is why they did that. The 6 months, anytime you create a policy, we'll call it cliff, where you sort of, cut things off at a specific time, you do create some weird incentives. And the issue with the 6 months and the way they've set it up is the 6 months can be a recurring 6 months. And so again, what happens is if a patient starts chemotherapy on July 1, they basically, for the next 6 months, are considered as part of the model. Whether or not they get chemotherapy in August, September, October, doesn't matter. They're in for 6 months. If they get chemotherapy again, 6 months plus 1 day later, they get another 6 months in the model. So again, you can imagine there are some weird incentives about what happens if you've got a patient who can get chemotherapy at 5 months and 29 days versus 6 months and 3 days. So you create those weird incentives. I think, when ASCO looked at their version of a model, we thought it made more sense that you basically paid based on months where patients were getting treatment, and those would be treatment months, and then you would have sort of non-treatment months. So I think, if you ask me, I would have preferred a model that looked a little bit more like that. But again, I think they lay out very nicely why they chose the 6 months. And again, big picture-wise, they wanted to capture the majority of the spending of a cancer patient, pick up some of that downstream, right? So you want to see not only all the stuff that we do at the very beginning of treating a cancer patient, all the CAT scans and the pathology, et cetera, but also get them into chemotherapy for a few months to see how we do in terms of managing symptoms, keeping people out of emergency rooms, et cetera. So they thought 6 months was sort of a nice blanket, to try to get a handle on that part of the way we deliver care.
The way the OCM is set up is they set a benchmark that you have to beat based on historical data. And of course, the actual expenditures for any individual practice probably varies quite a bit from practice to practice and geographic area to geographic area. How do they actually come up with the target that you have to beat? And how reasonable is that target that they're setting?
That is the entire devil in the details of this. So the first thing is important to understand is they actually broke from the way CMS has usually done these models, or like, for example, the way they did it in orthopedics, which was you took an individual practice's historical data and then had us try to improve on that. And actually, I like that they got away from that, because that model was always one that would, essentially help the practices that have been inefficient, right? So if I've been doing nothing and I'm allowed to try to beat myself, then all I have to do is, pick the low-hanging fruits and I achieve success. Whereas if you've had a practice that has really been doing all the right things and becoming very efficient, it becomes almost impossible for them to achieve shared savings because they've wrung out most of, the obvious inefficiencies and kind of low-hanging fruit stuff. So they decided to go to mainly a national target. There is a little bit of a blend of your individual data in there, again, for the purposes of, again, trying to get some reflection of things that they couldn't capture in their model. But at the end of the day, what they did is they essentially looked at a bunch of different variables, so things like cancer type and whether the patient had Medicaid and age and whether the patient was a nursing home resident, and then really comorbidities, a set of comorbidities, and they put a regression equation together. And the regression equation, when you put all those things in, will spit out a price. And that would be the price that they would expect. So, let's say you would take a lymphoma patient and, 64-year-old lymphoma patient who, doesn't have Medicaid and has, coronary artery disease and diabetes, and basically would say that patient should cost you $32,000, over 6 months. And then at the end of the day, they just aggregate all those patients together and they say, okay, you saw, 100 patients, lymphoma, colon, whatever. The regression equation said they should have cost, this amount of money. How much did we actually spend on your patient? And again, if you come in above, you get to keep the money. If you come in below, we'll talk about that. Right now, there's no, most practices aren't taking downside risk. But again, from a statistical standpoint, it's sort of your basics, metrics, statistics 201 regression equation. You got variables, on the right side of the equation. On the left side, you got a price. You ask me, well, how well does it work? So the one nice thing, again, to complement the way CMS has been running this is, we've been getting an incredible, so we happen to be an oncology care model practice. And so we have gotten essentially all of our historical claims data, which is an unbelievable amount of information since 2012. And they've given us a regression model, right? So it's not hard for us to sort of, run the model. And what we have found is when we run the model, basically the model predicts, again, for your people out there who know stats, the R squared on the model ends up being about, sort of 0.3, meaning the model explains about 30% of the variability. So there's 70% of the variability in what happens that is not explained by the factors in the model. So is that a good thing or a bad thing? Well, it depends on what you think is happening, right? So if you think that 70% is essentially inefficiency, then you say, well, there's clearly there's a lot of room that they can improve here. If you think most of that 70% are factors outside of your control, what patient shows up through your door, kind of what chemotherapy they have to get, then you say, gee, this model runs the risk of penalizing me for doing the right thing for the right patient at the right time. And so that view, the biggest sticking and concern that I have, it's that at the end of the day, the model is going to leave too many things on the table that really are not under the practice's control, that practices will get penalized for based on who walks through the door.
Well, that certainly has to be a concern. I'm curious to see when the numbers first come out and they kind of tell us how this is working. One of the obvious things that's going to lead to some variability, or at least seems like it should, is the constantly rising cost of the treatments that we're using in cancer care in general. And, the field is moving so rapidly that, the costs from a year ago in lung cancer, for example, before immunotherapy and now have to be dramatically different. So how are they accounting for changes when they're using retrospective data to set their benchmark?
Yeah, so I do think that having drugs in the model is probably the fatal flaw in the oncology care model. They don't see it that way completely. And again, from their perspective, they say, gee, how could I put together a payment model in oncology and not include drugs? So again, at an intuitive level, you say, yeah, I see why that's a problem, till you understand what you and I understand, which is this field and the price of these drugs, essentially where they get applied, is changing so dramatically that you just aren't going to be able to keep up with it. But to answer your question directly, so one thing, of course, they look at the growth rate. So how do you inflate the prices, right? So you look at historically what the cost of taking care of a lung patient should be. And then you take a look at all the practices in the country who are not part of the oncology care model, and you see, well, what has been the growth in cost for treating a lung cancer patient between, 2013 and 2017 or 2018. And you inflate the price that way. So some of that will be, to the extent that there are new drugs out there that have been utilized by a lot of practices, that will be picked up in the inflation factor. The other thing that they try to do with the model is, let's say you're a practice, for us, like an academic practice, who perhaps is an early adopter of a new therapy. So maybe we ran the clinical trial, for a new drug. And so, of course, the second the new drug is on the market, we're some of the first people to use it. We're comfortable with it. We know it, et cetera. So, that's a pretty common scenario. So they have this adjustment in there where they look at newly approved kind of FDA drugs, and they look at how much you're using of those compared to sort of other practices, and they eventually give you a boost for that. So it's kind of an early adopter boost. So they've thought about those kind of things. The bigger issue with drugs in the model is just the variability of who walks through the door. So again, take lung cancer, as an example, right? So lung cancer, with all the different possible mutations, right? You can have a patient who walks in with no driver mutations, has, PD-1 staining that's, very low, and they get something like carbotaxol. Very cheap regimen, probably costs Medicare $2,500 to $3,000, for 6 months. Then the practice down the street, the patient who walks in the door is someone who has, PD-L1 staining or PD-1 staining of greater than 50%, or has an ALK mutation, and now they're going to get a regimen that costs $50,000 or $70,000. Medicare has no way right now in the model of distinguishing those two patients. From Medicare's standpoint, both of those patients are the same patient, right? They were a lung cancer patient. Because Medicare doesn't have the molecular data, they don't even have staging data, right, and the claims, so they can't distinguish. And since treatment is so dependent on not just the cancer, but the stage and the molecular subtype, and the difference in costs are just, mind-bogglingly dramatic. You can have a 50 to 100-fold difference in cost. Their model can't account for that. So if you're large enough, right, if you see 10,000 lung cancer patients, a year, no problem, right? It all kind of comes out in the wash. But most practices, in a 6-month period, right, are going to be seeing, 15, 20, sometimes 11 lung cancer patients. So with that small of a number, you can imagine that it doesn't take too much of an imbalance for all of a sudden you to look really, really bad just by treating patients correctly with the drugs that happen to be approved for their molecular subtype.
Right. Yeah, I can see that can certainly impact especially smaller practices. And so let's talk a little bit about consequences here. So I know that there's two different risk plans that practices can participate in here. So are practices potentially going to end up losing money on this if they don't come in under their target?
So the way it's set up now, technically you never have to take two-sided or downside risk. So you could stay in the model for the 5 years and only take upside risk, meaning you get the shared savings if they're there. If you have losses, you don't have to pay them back. There's a couple caveats to that. And the major caveat to that is if after the first 4 periods, so which basically 2 years, right? So if at the end of 2 years, your practice or pool of practices have not achieved a shared savings, then either you have to leave the program, so you have to get kicked out of the program, or you have to take downside risk if you want to stay in. So that's the way it's set up. Now, to entice you to take downside risk, the way the model works, of course, is, as we've talked about, you've got a target price, and then you come in at a certain number. But the target isn't just a target. They take, in the one-sided risk, they take kind of 4% off the top. So immediately Medicare wants to save 4% on that. And then they sort of say, well, did you achieve shared savings? If you take two-sided risk, they take less off the top, essentially, right? So the amount that you need to get shared savings sort of is less. The other problem, though, with the way they set the system up is, well, how do you protect? So let's say I want to take two-sided risk, which nobody's taken as of yet, which you would expect, right? Because obviously no one knows how this is going to play out. None of us have actually seen any actual data yet for how we've done. So certainly no one wants to take the risk. But the other thing is, how do you cap my exposure? So the way Medicare did is they cap your downside exposure at 20% of essentially, the costs. Which you say, okay, well, that's not, so I can't lose more than 20%. But then you have to sort of ask yourself, well, that 20% is 20% of what? And that 20% is the 20% of total cost for that cancer patient over a 6-month period. So if I'm an oncology practice, right, my revenue from that cancer patient is essentially my E&M fees and whatever it is, my +6 margin on the drugs. But my 20% is going to include things like the total cost of the drugs, right? So most of that for us is a pass-through. The drug may cost $10,000 a month, but I'm getting very little of that. Most of that's going to, a GPO or, whatever the case may be. But the 20% is going to be on all that. If you run the math, it doesn't come too hard for us to see that we could be potentially on the hook for what would end up being like 350 to 400% of, net practice revenue. That's something they're going to have to sort of figure out. And you need enough of an incentive for people to kind of want to go in and do two-sided risk. And you need there to be, again, some risk involved of losing money, but you can't bankrupt practices, who choose to take two-sided risk. And I think right now that stop loss is probably, for most practices, just too much of a potential risk for that to make sense. So I think that's something that, again, over time they're going to have to visit. But again, in the first year or two, not a problem. Most people aren't thinking that much about downside risk right now.
And I suppose if they find that no one ever accepts that, then they'll have to make some kind of a change.
Right.
So, Dr. Polite, thanks so much for joining me today to talk about the OCM and the challenges that they're encountering with their rollout.
Well, thanks for having me on and letting me, share some of my thoughts on this very, very important program for the oncology community.
And I also want to thank our listeners who joined us for the podcast. You can read the full text of the paper at ascopubs.org/journal/JOP, published online May 23rd, 2017. This is Dr. Nate Pinnell for the Journal of Oncology Practice signing off.